Hello, everyone. Hello. Wait, hold on. I got to turn up my volume up because I turned it all the way down because it was like ding during the exam. Okay, now I should be able to hear you. Can I hear you? Somebody talk to me.
I can hear you.
Me?
Oh,
Good
hello. I can.
morning.
Hello, 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 hello. Okay. So first things first, we of course had one person miss the exam, so we cannot talk about it. But I will say as a blanket statement that I am very proud of all of you. I think most of you did, I mean, honestly, most of you did very well. I think I only have to send out like 1 or 2 CPTs. And that makes you have given me a lot of pride, and I'm very proud of you. And I know you guys really put a lot into this. So thank you very much. Very, very proud of you. And we're going to have to figure out a day so that we can do an exam review before the final, which our exam review isn't, or our final exam isn't until Friday. So we do have time. And hopefully the person that missed is able to take their exam tomorrow after clinical. So I should be free to go over exam 2 after tomorrow evening. Okay, so we'll figure that out together. Otherwise, we are going to start with ACLS just so we can finish off cardiac. And then depending on the time, we still need to go over shock, which is kind of the biggest component to the next 3 portions. We have shock, then burns is going to be our second most important if we're prioritizing. And then third is going to be our trauma, casualty, emergency kind of nursing. Okay. So I'm hoping to do as much as I can today. Maybe because last term I had to send out a pre-recorded something. I don't remember which. It was one of these topics. I think it was trauma that the students had to watch on their own, and it was like an hour long of just me sitting in my guest room with a lecture. So I may have to do that again just because I do want to have that opportunity on Monday to have a review for our final. And we also do have time together with our simulation, but we can't do a lot of test review that day because really any test review that day because the 2 Dayton students are not going to have that same opportunity. Somebody else is going to be doing their simulation. So that wouldn't be fair to them to do any type of review on those 2 days with all of you other students and not give them the same opportunity. So I wouldn't be comfortable doing that. So anywho,
Could you record it?
No, I do not record test reviews. But see, so Amara, what I mean by that is like that simulation day is like it's like an 8-hour day, like a 7-hour day. So like it would have to be very specific, like time frame to say like, okay, this is a test review. And I would never want to not give you and the other student and Chantel the same opportunity as everybody else. That's all. So
Is there like maybe like we can log in like the last hour of the lab simulation? That way like everyone can get a test review? I don't know. I
well, no,
don't know.
it's
I
not.
don't want to be
So I want to do a test review on Monday. I'm going to do a whole test review during our lecture on Monday, which is why
Oh,
I may be sending out a pre-recorded lecture like in the next couple days that you will have to be responsible for watching because I will not be teaching it. Like I'm teaching it, I'm sending you the recording of me teaching it, but it's not going to be like this.
I'm sorry, Jessica. Can you let Sharia in, please?
Yes, thank you.
Thank you.
Where? Oh, it's probably over. I have nobody in my waiting room. Uh, yeah, can you let them know that I don't have anybody in my waiting room? I don't know what's going.
I just messaged her.
Oh, okay. Okay. Is anybody else having trouble getting into Ring Central?
I
didn't
did
have
for
any
like
problems.
10 minutes, but then it was fine. So I don't know what happened.
Huh.
Like it kept telling me that your Ring Central link was invalid when it was on my computer and it's bookmarked. It's the same one that I've used. And then when I switched to my iPad, it kept telling me that there was no available connection or there was no available host. And I'm like, well, I know that there's a waiting room, but then it
Yeah.
kicked me out and I signed back in and it was fine. So I don't know.
I don't know either.
Some of our other classes are still open too, so they might be in the wrong waiting room. So I let her know to double check what waiting room she's in because some of our old, so she might have hit the wrong link. I did that one day.
Okay. Amy, did you get in? It says that and it was just lagging and frozen for me and rejoined. Oh my, we're gonna have issues today, aren't we? You know what? Let me just connect my hotspot right off rip here today. Cause I am not trying to play with these problems. So I did like the filled in slides. So Brandy, can you reach out to Amy Lou? She's having issues getting in, I think. But I don't have anybody else in my waiting room. So all right, guys, turn your cameras on, please.
You want me to call her, Jess?
I don't know. She's emailing me. Whatever's easier for you.
Okay.
She says that it says I'm the only participant. She can't be in the wrong, or she can't be in the right place if that's what it says. I'm not sure. Okay. Also, I'm trying to make a notebook LMC. For the dates to
think Kiara's in the wrong lane too. She's one participant. Oh, never mind. She said she heard you, then it went blank.
Okay. All right, so everybody can see my screen. Let me try to zoom a little bit. How's that look? Okay, so, we are all, at least you should be and have to be for clinical, and for nursing school, BLS certified, okay? But after BLS certification, we have ACLS, which is Advanced Critical Care Life Support. And then we have PALS, which is Pediatric Advanced Life Support. And that's it. So with BLS, we are told, the first thing is that we have to check our scene, right? And make sure that it's safe. Because remember, we don't delay CPR for anything other than the scene is not safe. NRP. What's NRP?
The
Oh,
neonatal resuscitation protocol.
Yeah, which is very different than PALS. I learned that. Yes. Okay, so our scene is safe. We run over to our patient. We say, hey, are you okay? They don't respond. We go and we check a pulse for, you should check a carotid pulse. Sometimes if your patient has a very weak pulse, but they have a pulse, sometimes you won't be able to feel it radial because their cardiac output is crap. And you should be going for a femoral, a carotid, usually a carotid, especially if it's a stranger, you don't want to stick your hand in their pants. And then if it's a baby, where do we check a pulse? Brachial, correct. So we want to check if the patient is breathing. And then we want to give compressions 30 to 2. And if we have if we are by ourselves, we are one human, right? We talked about you should give a full round of CPR, which is 2 minutes, because they say that your blood has enough oxygen components to circulate for 2 minutes to make sure that you get enough oxygen to your brain before you have to run and either call 911 or get to an AED if you don't have that right in front of you, okay? If you're in the hospital, you're gonna start CPR immediately. You're gonna hit the code button or you're gonna yell for help, and somebody's gonna come flying down that hallway with the code card. But by the time they get into that room, you should have already initiated CPR. Okay. You want to make sure when you're compressing that you have full depth and recoil. That means you're going in, I believe, 2 inches, 1.5 to 2 inches. I think it's 2 inches. And when you recoil, you have to bring your hands all the way back up, because when you compress, that's contraction. When you recoil, that allows the heart to fill back up for dilation, okay? So if you're not giving that chance to have full recoil, you're not gonna have good cardiac output, all right? You want to have the most minimum interruptions between compressions and breaths. I'll never forget, I did let her in. I was basically running a code all by myself at Akron General, and it was absolutely ridiculous. If you had me in 2210, you may have already heard this story. But I was I was passing meds with a student across the hall. And my student who was in there with a wound care nurse doing wound care on a patient who was chronically trached. They had him turned to the side. He went into respiratory arrest, which then led to cardiac arrest. And my student ran in to come and get me and said, I need you. Something's wrong. I run into the room. There's nobody there. There's nobody there. There were 4 nurses, and I'm not going to hold my nursing student accountable because she's a student. And there was a whole floor full of nurses that were capable of doing their job. There were 4 nurses that ran in and out of that room that did not start CPR. I was the one that started CPR in that room. Okay. So we do not delay CPR. I also remember they had their med nurse come in and tell me that I needed to stop my compressions to put it to do a backboard. Excuse me, ma'am. That is not part of ACLS protocol. I am giving adequate compressions right now because, by the way, I can feel his ribs cracking under my hands. So you can wait until a pulse check. Okay? And that is my point, is there is minimal interruptions of compressions, okay, and breaths. You do the things in the proper way so that, because if you interrupt, and by the way, you interrupt for a backboard, you have to stop compressing and flip the whole patient towards you to put a backboard under just to put them back, right? If you really think about it, that could be like 10 seconds. 10 seconds of someone's life and death. Okay, so at this point with BLS, this is kind of all we do, right? We're like, okay, I'm giving compressions, and with BLS, you're also taught how to attach an AED because we can see AEDs in the wild, right? And then the AED tells us what to do. It says if it has a shockable rhythm, it'll say shock. You hit the button, blah blah blah, right? So, when it comes to ACLS, this is when, if you're on a regular unit in a hospital, the code team comes and they take over. Okay?
Bless they heart,
Huh?
bless they heart.
I used to love that adrenaline rush. I really did. And then when you have a lot of people die, you kind of like it a lot less. So your code team arrives and they take over. When I say they take over, that doesn't mean that your med surg and tele nurses and step down nurses don't still give compressions or are a part of the code. They absolutely can be compressors. But at that point,
Can I say something too, Jess? The
Yeah.
other thing is, if you are the nurse, if that patient is your patient, you need to stay in that room even
Yes.
when the code team comes, because the code team does not know that patient. You know that patient. And so the primary nurse needs to stay in the room to answer questions. Sorry, now I'm done.
No, that's fine. Which really sucks, by the way, when it's your first day back after like 5 days off and it's like 7:05 and you just got report and you don't even know this dude, and you have the resident looking at you and asking you all these questions. You're like, dude, I just got here. Like, I just got here. Okay. So yes, you need to stay with your patient. Just because they take over doesn't mean you leave the room. Okay. So at this point, we are assessing roles. Okay. There are 5 roles. There is the compressor, there is airway, there is the recorder, there is med management, and then there is the lead. Okay. The lead is the physician, the person leading the code. Okay. This is the person that is making the calls, and they know that they're in charge. They know they're making the calls. They shouldn't have to be told. Okay. During that code at Akron General, the resident walked into the room and said, "Who's running this code?" And I looked at him and I said, "You are." I've never been so dumbfounded. Like I will never forget. I will never forget this for as long as I live. It was the most ridiculous situation I've ever been a part of in my life. So at this point, peoples that are compressors, they rotate out every 2-minute cycle. Okay. And sometimes in between, if your person that is compressing is feeling fatigued, they're not giving adequate compressions, this is not a I'm picking on you situation. Okay. And it never, ever will be. This is me saying, I'm in charge of this code. I'm leading this code. Hey, Lisa, I see you're getting fatigued. Your compressions aren't adequate. I'm going to switch you out.
You will not tell me, tap me out.
She said I'm out. So,
Your
but
arms get tired
But
very
this
quick.
is that moment where you can have people be like, no, I'm fine. I'm good. No, I'm telling you that this is a person's life and death. So I need you to back away from the patient and I need you to switch off. And that person compressing next, they are right behind you and ready to go. Okay.
Because it's exhausting, guys.
It is
CPR is exhausting. You don't realize how physically exhausting it is, but that 2 minutes by the end of it, if you're doing
Feels like
CPR
10.
correctly, you're whooped.
And just think about it. This is the most adrenaline you've had in a long time or ever. Your heart is racing. You are in fight or flight and you are fighting for that person's life. Rodnea said, would you finish the cycle first? No. If that person was not giving adequate compressions, they need to be switched out. And that happens very quickly because that person standing behind them is literally ready. I have my hands here. That next person, their hands are right next to my hands. As soon as I move my hands, those person's hands replace my hands. So there really isn't any delay in care when that situation happens. It actually does not happen a lot. Because what happens more often is that you're compressing too fast because your adrenaline is running so hard and you're so intense that you're just like boom, 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 boom. But really, it should be at a rate of staying alive, da, 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 staying alive. I believe it's a beat of 120 actually, is the goal. But you want to have full recoil, right? So, and when you are compressing out loud. You are projecting your voice. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. You are continuously speaking out loud. Everyone in that room needs to know exactly what is happening at every single room. Okay? The person that is on airway, they are doing either a bag valve mask or up until intubation. So when at that point, either your respiratory therapist, your nurse practitioner, your ICU resident, your ER resident, your ER attending, your intensivist, somebody is anesthesiology, if it comes down to it, somebody is intubating this patient, okay? Once you have an airway, you do not have to stop compressing to give breaths once you have an airway, okay? When you don't have an airway is when you do 30 and 2, is when you have a bag valve mask and you have to stop compressing to be able to give an adequate tidal volume with both of those breaths, okay?
The other thing,
Go ahead.
I was just going to say, the other thing is that anybody typically in a controlled situation, either your respiratory therapist or your provider is going to be the one intubating your patient,
Yes.
putting in that advanced airway. However, anybody who is ACLS certified is able to establish an advanced airway. It is part of ACLS protocol. But as I used to explain all the time, if there's an RT or doc there who's intubated before, that's who we're going to have intubate, because I don't do this on a regular basis as an ACLS nurse, right? So I'm not the one you would want to choose. However, if somebody needs an advanced airway and there is nobody else available, then that nurse who is ACLS certified can put an advanced airway in.
So, and just to piggyback on that, I will say that you would have to be in a situation where you'd had nobody, which is hardly ever the case during a code. You usually will have the hands that you need. There's always a variable. There's always going to be that time where something happens and you don't have the people that you need. God forbid. I will say that even with my experience in critical care, I would have never felt comfortable to intubate until after I spent 2 years in the OR watching intubations every day, all day. Because yes, you can see it 100 times, but actually physically doing it is something very, very completely different.
It is very different.
This is not a situation where you're like, oh, I have ACLS, I'm going to intubate. And then everybody's going to look at you and be like, you can leave. Because that's crazy. Okay? Because you're crazy. Okay.
But where you may see this, and only because of my experience, is your smaller outlying hospitals in that are in outlying areas, and sometimes at night the only physician for the whole house is the ER doc, and if that ER doctor is already tied up with a trauma or something that a code that's going on in the ER, like that, those are those type of situations where you could potentially be the only one available.
Yeah. And Kelsey put in the chat, she said, in 25 years in the ICU, my aunt has done it once and there were codes at the same time. So that was a really good point. So say you work in a big hospital or small, whatever, and there's multiple codes called at once and all of your providers are at different codes and you're the last one called and there ain't nobody coming, then yeah, absolutely, that could be a possibility. I will say, when you get ACLS certified, there is not a huge portion of the class that is taught on intubation. There's not. It's more about the drugs and the protocol, okay? So while all of these things happening, we have my compressor doing her thing, his or her thing. We have our airway, they're doing his or her thing, okay? I have someone at the crash cart with my meds. They are immediately... Oh, I forgot the administrator, the medication administrator. There's 6 roles, okay? So I have my person on at the code cart drawing up my epi. Hopefully you have your quick access epis. You're not drawing them up out of glass ampules like they did back in the day and slice our fingers open. I've done it. And they are handing epi over to the medication administration nurse and saying, here, I have epi. And then there's a little person standing there with a little pen and paper with a watch. And they're watching and they're looking at the clock and they are writing code began 10:07. Compression started. Epi given 10:08. Pulse check 10:10. Airway ETT 10:11. Epi 10:12. That is their only job, is to be the recorder. You should never be playing all of the roles. This is a team sport. This is not a solo sport. Okay?
And there is an Epic code recorder. So like, I know we as older nurses have a tendency to write, but there is a code recorder in Epic that has everything and you can document.
They also have apps. that you can download on your phone for ACLS documentation. A lot of the ICU residents, the first, second years, that were really trying to get their bearings on and leading a code would have the app, and it would time, and it would remind them of things that they needed to ask or things they needed to do, right? So also during this time, most likely somebody is getting an ABG. And this is going to be one of your critical care nurses. They are bedside, they are getting labs, a whole rainbow of labs, and an ABG. That ABG is being handed off to respiratory. Respiratory is going to run down the hall wherever they need to go and run that ABG. And then they will come back with that report. If I'm the one getting all these labs and ABGs, I'm handing off my labs to someone else. Someone else is going and sending my labs stat. Okay. And remember, if there's a lactic in there, if there's an ammonia in there, they have to be set on ice. So we need to speak to our team members out loud every time. Everything that you do is out loud, because that is how you work in chaos as a team. Okay. So ACLS protocol. This begins with, is my patient in a shockable rhythm? Epi's already been given, right? My patient coded. Somebody's already compressing. I have someone on my airway. Someone is recording. Someone is leading. Someone is passing meds. I have Epi given. Pads are placed on the patient. I'm looking at the defibrillator and I see VFib. My leader, my physician, NP, advanced practice, whatever, is saying, patient is in VFib, let's charge to 200 and shock. So the person that's manning the defibrillator, which is on the code cart, dials it up to 200. They hit the button, the charge button. When it is ready, it goes beep. And then all of you say, clear. Your hands are off the patient. Your hands are in the air. And you say, clear. Everyone is clear. And that person at the defibrillator presses the button that says shock. A shock is delivered and you immediately resume CPR. Immediately. Even if your patient spontaneously went right back into normal sinus rhythm of that one shock, which doesn't normally happen, but if it did, you are immediately resuming CPR until you can physically feel a pulse at the next pulse check. Or that patient is sitting up in that bed saying, get off of me. Okay?
So where are we at on this chart? 'Cause-
I'm just talking first.
Oh, I'm thinking about where.
Well, yeah, I was gonna say, because over there.
We're gonna get it.
Okay.
It says pulse VTAC. I thought it was pulses,
Pulseless. It is pulseless.
but that says pulse. So
That's why I was
that,
confused.
That is not right. That should say pulseless. That's a very good call. Because pulsed VTAC, your patient with a pulse VTAC, is cardioversion. Yes. So that is pulseless VTAC is a shockable rhythm. So now we have given our epi, our pads are on. One shock has been delivered. CPR has been resumed. And now it is time for a pulse check. The leader says, pulse check. Everyone stops. You can continue giving breaths during this time if you have an airway. And there's going to be someone at the carotid. There's going to be probably somebody at the other carotid. And there's going to be 2 hands in the femoral. And there are 4 hands checking for a pulse in this moment. This needs to be fast. You cannot spend 20 seconds down here trying to search for a pulse. You either feel it or you don't. If you don't, you continue CPR. Okay? If you do, then we need to look at the monitor and see what kind of rhythm we have. Okay? If I have a rhythm with no pulse, what is that called?
Rhythm and no pulse.
A rhythm and no pulse. We talked about it very shortly.
Rhythm but no pulse.
A rhythm with no
Pulseless
pulse.
electrical activity.
Pulseless electrical activity. That is called PEA. That means something's happening in there, but it is not actually giving a cardiac output. It is not a shockable rhythm.
So is that fine in Sicily?
No. That is PEA. This can literally look like bradycardia.
Oh, okay.
It can look like a rhythm
Yeah.
with no pulse.
I was getting ready to come to that, so I was like, what is PDA and what is PVT?
PVT would be pulseless VTach. In here, right here.
Oh,
Ventricular
Yeah,
fibrillation,
they didn't need
pulseless
all that.
VTach,
Yeah.
um, pulseless electrical activity, and asystole. Okay? So,
It's throwing me off. I say shockable rhythms, I thought we don't shock it system.
No, one's on one
it
side.
says no shock.
No one's the top on the
I know, but then it says no. Shockable is on the right. I guess that would be your left. I'm gonna find something better because I don't wanna confuse anybody. But, so, let's just go through this a little bit. So, if my patient has a shockable rhythm, which includes ventricular fibrillation or pulseless VTach, we are going to deliver a shock. As soon as that shock is delivered, we will continue CPR for an entire cycle. After that cycle is complete is when there is a pulse check. When there's a pulse check, we are analyzing, not only am I checking for a pulse, I'm also looking at the monitor. If my patient continues to be in VFib or pulseless VTach, I am going to deliver another shock. Okay? Epinephrine is given every 3 to 5 minutes. Now, ain't nobody waiting 5 minutes, by the way, during ACLS. During a code, there is not one human in the world that's going to be like, let's wait another 30 seconds. No, your recorder is watching the clock, and as soon as it hits 3 minutes, they are saying time for epi. And by the way, the person that's manning the cart, they already got it ready. They're already ready. They have it in their hand. They're handing it off as soon as you said it. Okay? Because they're literally, that is their only job. They are waiting for you to say it so they can hand it. Okay?
And that person who's running the code, a lot of times the person who's recording, that the person running is going to ask that recorder, how many EPIs have we given? How long was my last EPI? You know, have we given, like, it's gonna, they're gonna ask for that back.
Absolutely. During that situation at Akron General, the nurse, this poor nurse, she was so green. She had never seen a code before in her life. She was not ACLS certified. This patient was pulseless. Okay. And she looks up and she says, how fast do I push it? And we all looked at her like she had 17 heads.
Oh, God.
And somebody said, slam it, because the patient is dead. The patient's not getting deader. Okay. So when you're giving life-saving medications, you're giving epi, you're giving amiodarone, you're giving calcium gluconate, you're giving bicarb, you're giving whatever you're getting, I don't care about, oh, well, if the person was alive, I would give it over 2 minutes. No, the person's dead. Okay. So we're going to give it fast. All right. When your patient is in PEA or asystole, we are continuing CPR cycles, okay? And within those CPR cycles, we're giving epi every 3 to 5 minutes. We're giving breaths when we're supposed to, but never in the ACLS protocol. If that patient never gets to VFib or pulseless VTach, there's no shock. We can't shock something that has no electrical rhythm, okay? It's just going to be meds and CPR and air, okay? So what I would like to do this is important though. So amiodarone is not your first line medication. Epi is always going to be your first line medication. It does become appropriate within ACLS, and when it does, there's a max of 2 doses, unless that physician overrides that, which also doesn't happen commonly unless they really feel strongly that another dose would be okay. But the first dose starts at 300, and the second dose is 150. And at that point, when you're giving amiodarone and epi, you're rotating them, but that epi is never going to go off that 3 to 5 minute schedule. I'm not holding off on epi to give amiodarone, right? I'm just rotating them. So I'm giving amiodarone in between my epis, okay? First dose is 300 milligrams, the second dose is 150. When you achieve ROSC, okay, so this is return of spontaneous circulation. That's the goal, okay? We want our patients to come back to life, all right? We want to make sure they have a good pulse, a good strong pulse. If you're on a unit that's outside of the ICU, this is when you are get in that bed, you're unlocking the bed, and you're running down the hall. And somebody is already down the hall holding the elevator for you. Okay? You get into the elevator, you go to the unit, they already know you're coming because the nurse manager of the hospital, she's at the code too. And she already called the ICU and said, hey, I need a bed. Like right now, I have a patient coding and we got them back. So we already know where we're going at this point.
And a lot of times in a lot of the ICUs, if somebody's open for an admission, they will put that person on the code pager so that that nurse is probably going to be the one to take that patient. When the nurse that goes to the code will be the one that would take that admission.
So I wanted to try to find more of a realistic code. All right, let's see. I want them to be able to hear this.
Hospital, I'd be dead.
61-year-old John Juris of West Salem started sweating.
Hold on.
I just had a weird, strange
that?
feeling that something was definitely wrong. I remember telling her I need to get to the hospital.
He never goes to the doctor. And when he says he needs to go, don't question it.
John's girlfriend, Janet Carter, decided to drive him to Salem Hospital. She felt his heart stop beating when she pulled up outside the emergency department.
I was laying on the horn and realized nobody could hear me, so I had to get out and go in.
Janet ran by Ola Yost, a trauma nurse who was just starting her shift. Yost noticed another nurse, Hattie Lowry, plus an emergency department technician heading outside.
I didn't know what was going on, but she looked like she was in a hurry. So I ran after her, and immediately she yelled for a stretcher for me to go grab a stretcher. You could hear in the tone of her voice that this was a serious situation. CPR is just one of those first things you got to keep that heart pumping to get the oxygen flowing to his brain. She was performing using the seat as a backboard and performing against the seat, and you could see the whole car moving while she was doing that. Once we had enough help, we got him out of the car and right onto the stretcher. As soon as I jumped on top of him and started performing CPR, that's when it really slowed down. It was very slow motion, seeing him and looking at how bad he looked at that time, and just knowing that we need to get him into a room fast.
There were so many people responding to his situation. It was incredible.
Emergency physician Jeff Hemstreet was part of the team that spent 45 minutes trying to resuscitate Juris as his heartbeat returned and then faded several times.
He was breathing on his own, clenching his teeth, and that's a sign of brain function. And this was a ways into the resuscitation still. His heart wasn't beating, and he required some medication and energy to restart his heart. He was able to be taken right to the catheterization lab immediately following his resuscitation. Things definitely aligned in his favor. To be at a hospital with an excellent emergency department staff that was very skilled in his resuscitation, immediately followed by a cath lab available around the clock. Can't believe to see you sitting upright talking. To see him with his new lease on life, that's really a gratifying moment.
It's amazing.
You see those
Absolutely amazing to me.
He never went to the doctor.
He probably does not know he has Graves' disease. You are probably right. So I want to,
That's probably where his heart trouble came from.
so this is a mock code training video. So,
Hey, John, what can I do for you?
John, what's happening here?
I'm just gonna grab my vital from
What's the matter? Oh. Where are they? Help me here.
Can I just get a cell?
Okay.
remember this is mock,
I don't want to leave you.
but he's trying.
Try to breathe. What do you think's happening?
I'm not quite sure. Hey, Kristen, you rang the bell? Could you grab Heather for me, his nurse? Okay.
So this is
Where is she?
probably like
Come
a
on.
next.
She should be coming soon.
We may not have the full education, but you walk in there and you see the face of distress, you're like, something's happening. And
Hi, can I
know
get
what-
RRT to room 369?
What's happening?
And then there's just called an RT.
This bad room
Which-
came in.
I don't know what they're.
Attention, RRT room 369. Attention, RRT room 369.
Try to
Attention,
breathe.
369 RRT.
Kirsten, what's going on? His respiratory is 28, his blood pressure is 90 over 60, and his heart rate is 130. John, how are you feeling? Not good? In your belly? I'm gonna take a listen to your chest. No, okay, I'm gonna take a listen to your chest. We're just gonna take your Johnny down here. Are you having any pain? Can you tell me where it is? You're having a lot of pain in your belly? We gave you some medicine, did that help?
No.
Monitors on. So he's in a wide complex tachycardia. Can we go ahead and put the hands-free pads on? Yes. His heart rate is about.
What is this rhythm? This is VTAC. Our patient is talking to us. So that means this is VTAC with a pulse. Okay? And remember, our patients can have VTAC, sustained VTAC, but it cannot sustain long. Okay? Our hearts cannot rapidly work like this for a very long time. If we don't get him out of VTAC, he will cardiac arrest.
160.
Hang in there.
So his heart rate is very fast right now, and his blood pressure is low. We're just gonna put some more pads on him to make sure he's
And
doing
remember, the
okay.
higher you
How are you
want
doing, John?
the worse your cardiac
I'm just gonna put
output.
these stickies on here.
You can't tell what's happening right now.
It's gonna be low because your cardiac output
This will be
sucks.
cold. There you go. Alrighty. There you go.
Hang in there, John.
Is the pain getting any better?
This, they started a rapid.
Oh, no, don't say that. Don't say that, John.
And did you, he just said something bad is happening. That is called rapid.
John.
Then John's going out. John's out. And somebody nurse.
So he's not breathing and he doesn't have a pulse? Kirsten, can you call a code blue? It's called.
Okay.
I'm gonna lower the bed.
Okay.
So now I'm mad, right? Now I'm mad, okay? Because it should have taken, right, he's already hooked up to a monitor, but now I can't see I can see it. No, it's still VTAC. It still says VTAC on the monitor.
Well, I'm just saying, I didn't see those squiggly lines, I just heard the beep.
I heard the beep, right? But then she spent a long time. I mean, granted, if we really looked at the seconds, maybe it was like 5, but it felt way too long. It felt way too long. Then she says, somebody call a code. She goes to reach for her stethoscope. Excuse me, ma'am. This is what I'm saying. There is no delay. You've already said the patient is pulseless. While you're compressing, then while you're actively compressing, you can say call a code, right? We are not delaying.
Start compression. Nancy, can you switch it over to AED mode, please?
Code blue, room 369.
It's on AED mode.
Do not touch the patient.
Can you get the CPR board ready and we'll put it under?
Stay clear of patient. Deliver shots now.
Stand clear.
Hold on. Wait, hold on. Because number one, that bed rail is up. While you're compressing, if that bed rail is up, there's gonna be somebody that is literally like putting it down for you. And I'm not kidding. And I know you guys probably won't be able to see me, but I'm not kidding. You'll have nurses, especially the short ones, that have their knee on the bed and they're compressing like this.
Yeah.
Both knees on the bed. That's why a lot of crash carts, when they get fancy, they come with a stool. I ain't never used the stool. I'd rather put my knee on the bed. Okay.
And I am the opposite. I use this stool every single time.
Brandy cares about her knees. I do too, but man, after I heard him. So anyways, listen. So our bed rail is up. Somebody needs to put that down. Okay. Then what just happened here? Because she's compressing and then all of a sudden she stops.
Nancy, can you switch it over to AED mode, please?
Code blue, room 369.
It's on AED mode.
Do not touch the patient.
Can you get the CPR board ready and we'll put it under?
Stay clear of patient. Deliver shots
Stand
now.
clear. Everybody
Press the
clear?
orange button now.
Shocking. 1, 2, 3, shock.
Shock delivered.
So what we're not seeing here is a full code team. That's what we're not seeing here. We're seeing nurses that are practicing a mock code that may have never seen a code before in their lives. And they're practicing, which is, we need to practice these things because when they happen to you, that's how we deliver the correct things, right? So this poor girl in the red, she don't know what she's doing. She's trying to put the side rail down. She put it up higher.
I saw that.
Okay. They're turning on an AED when in a real code, your leader has arrived. The person leading the code, whether that is the advanced practice nurse or a resident or an attending, and they are the ones that are looking at the monitor and making that call. So we know he was in pulsed VTAC, and I don't know who's controlling the monitor, but when John first went out, it still looked like VTAC. So maybe he's now in pulseless VTAC. So when they attached it and put it in AED mode, the guy said, stop touching the patient, which in order for the AED to read the electrical activity, you have to stop. Okay. And then the AED sensed that he had a shockable rhythm, which is then when they delivered the shock. Okay.
Start CPR. Get the board. Can you pull the bed out?
If needed, begin CPR.
He's saying CPR. We got too much malarkey happening. First of all, I'm redoing this video before I post this online. You guys are too much here.
Nancy, you're going to resume compressions. Kirsten, I'm going to have you do the airway. I'm going to be team leader.
Now, granted, if we would slow it down, maybe.
Brian, why don't you go ahead and get the code cart ready? Can you pull out the medications and the respiratory box for when respiratory gets here?
It's important that somebody pulls the bed out from the wall so that the respiratory person can get in there and do it behind the head of the bed.
I have a good pulse. Let's do a couple more rounds and then we'll take over.
Oh, they didn't hear me.
Hi, Heather.
I had no idea you couldn't hear me. I've been talking and talking and talking. Ah, that's annoying. Okay. What I was just saying was that there was a huge delay in care again, right? The AED said to continue CPR. You had these nurses walking around like, somebody started calling for a backboard. Somebody's walking around the bed. They're moving the bed out, which, by the way, is a good thing to do. You want to move the bed away from the wall so the person that's giving breaths can stand behind the head of the bed. Usually the head of the bed is removed so that they can have access to the airway, and it will help with intubation.
And the rails of the bed are still up.
The rails of the bed are still up.
And not a single person has on gloves. I know it's mock, but not a single person has on gloves.
Yeah. No, so I will say that nurses nowadays have gotten a lot better about gloves. You'll see a lot of your older nurses that if they lived through that time where gloves were like, whatever, they're gonna jump on that chest and they're not gonna care if they have gloves on or not. If I was in a situation,
I would jump on the chest without gloves. I'm not gonna lie.
Yeah, I agree. I would also jump on the chest without gloves. But once somebody got me off and I knew I was back in circulation, I would probably put them on. If I was waiting in line to be the next compressor, I have gloves on. If I'm first one on scene, I don't have time to put gloves on. I'm sorry. I can wash my hands. And granted, it sucks when there's a lot of blood and like vomit and stuff, but I mean, it is what it is at that point. Because we are looking like.
Let me tell you, even with PPE, if you don't, you're nurses, you're going to be nurses, and I promise you, you are going to wear body fluid at some point.
Yes. Unfortunately, yes. It is an unfortunate truth.
Yes.
Okay, so now that I know you can't hear me while this is going, I'm gonna stop talking while it's playing and then I'll pause it to talk.
I'm from the Code Blue team, and I'm going to assume the role of the team leader. Can you give me an SBAR report, please?
Patient is a fresh post-op, 2 hours with abdominal surgery. He was complaining of pain. We came in, we medicated him. It was unrelieved. He became unresponsive. We did start compressions and we shocked him once. We are now resuming the compressions.
Excellent. I'm going to have you take over as the reporter. I'm going to assume the role of team leader. Nancy and Kirsten, you guys can continue compressing and ventilating. Brian, you can be a relief compressor. Me.
So the job of the team leader is to assign the roles, okay? A lot of teams that are responsible for the code team there are some units that automatically assign roles at the beginning of the shift, just in case something happens. But if roles are not predetermined, then the leader is responsible for assigning the roles. Now you can be like, I'm on the cart. I'm on recording, right? You can volunteer that, but it goes very much easier when the leader assigns the roles.
Mike, I'd like you to take over on the monitor, please, and let me know when it's 2 minutes, when we can redefibrillate again. We're going to switch that to manual mode when that time comes. Whitney, would you please ready 1 milligram of the 1/10,000 of epinephrine, please?
We heard there was a code blue. We thought we'd stop.
Are you part of the code team?
No, we're not, but we thought we'd come and see if we could.
Are you
assist.
part of the code team?
Yep.
I'm just gonna have you stand back against the wall for right now.
Okay.
And if we need you, we'll have.
This is very normal. So, and by the way, if you haven't noticed, this is the first time this guy's getting epi. Because yes, those BLS nurses are trained to put on an AED. They are not ACLS certified, which means none of them cracked that code card and none of them gave epi. Okay? They were only doing their basic life support until the code team arrived. The code team arrives, the team leader assigns roles, then she says, I want this much epi. This person that's talking right now, that is the recorder. It is her responsibility to write down every single name that is in that room and why they are there. So if I have people that don't need to be in that room, because people get excited. They're like, oh my God, a code, I want to go. Are you necessary for this code? Yes or no? If it's a no, you're going to leave. Okay? You're either going to stand on the back wall like a fly on the wall, or you're going to step out in the hallway, because too many bodies is too much. It's too many cooks in the kitchen.
We don't
Have
know.
you jump in?
We used to call them the
Yep.
Okay.
1 milligram of epinephrine is ready.
Good.
Capnography is 18.
Very good. Thank you. We're going to continue with this. Let me know when it's time to redefibrillate this patient. And like again, I want you to switch that to manual mode. You've already done that. Good. We have good pulses with each compression.
We are at 2 minutes.
Okay, switch please. Compressor ventilator switch.
Okay.
Mike, patient remains unresponsive. Go ahead and provide your defibrillation.
Everybody clear the patient, please.
No, Brian.
Shocking on 1, 2, 3. Shock delivered 150 joules.
You guys
by
haven't
phase.
switched. Make sure you're switching every 2 minutes. I want you guys to switch out. Whitney, go ahead and give that 1 milligram of the 1 to 10,000 epinephrine, please.
Okay, IV is patent
Very good. Excellent.
and flushed.
Good.
1 milligram of epinephrine given.
We have good pulses with compressions. Whitney, I'd like you to ready 300 milligrams of amiodarone. Team.
So if you feel like this is extra, it's not. Okay, I know that this is mock, but this is real. The way that they're talking to each other is real. She is saying, I want epinephrine given. The person on the cart is handing epinephrine over to the person giving meds. When that epi is in, the person that gave meds says epi is in, so that the recorder can write down exactly when it happened. So all of this talking, this is not extra. This is protocol, okay?
If this patient remains in this rhythm, after our third defibrillation, we're going to administer 300 milligrams of IV amiodarone.
300 milligrams of amiodarone ready.
I'd like you to ready 40 milligrams of vasopressin as well. Heather, would you
I'm
please let me know
sorry.
when we can repeat our epinephrine?
I will
Doctor?
announce every 3 minutes.
Can you please clarify for me, did you want 40 units of vasopressin? You said 40 milligrams.
Thank you for stopping the line. Yes, I meant 40 units of vasopressin. Please draw that up and have that ready.
40 units of vasopressin is
So just like when we're taking verbal orders from a physician over the phone or in person, we are still required to do a talk back, right? So you're telling me you want vasopressin 40 milligrams. I'm saying you want 40 milligrams of vasopressin. No, I meant 40 units. Okay, you want 40 units. Yes. Okay? Because we need to.
Ready?
Brian, you get compliance there, no problems?
In an emergency.
I'm getting a little harder to bag.
Okay.
Capnography is decreasing.
Nancy, you fatigued?
I am.
Kirsten, could you take over for compressions, please? Okay, this is a fresh post-op. We've given 500 cc bolus of fluid. I think we should probably go ahead and repeat that bolus. Heather, he's got some blood on the dressing. Was that there previously?
Yes, the dressing's unchanged.
Okay. Has belly exam unchanged?
Yes.
Okay. Mike, can you go ahead, or Whitney, can you go ahead and administer another 500 cc bolus? What was he complaining about?
He was complaining of abdominal pain, but doctor, I did assess his lung sounds prior to his arresting, and he had bibasilar rales.
Okay, let's
Have you
be
considered
judicious
an amp
on
of sodium bicarb?
Excuse me?
Have you considered an amp of sodium bicarb? Or how about calcium chloride?
Thank you for your input. However, neither one of those are indicated in this code. The patient is not acidotic, and there is no indication to give calcium. So thank you, but I'm running this code right now.
I have a 5.
So this person is chirping up in the back and being like, hi, excuse me, what do you think about sodium bicarb? First of all, where's the ABG and where's the reading, right? So are we assuming that we have an ABG, the doctor has received it, and she's saying this patient is not acidotic? I'm not giving a bolus of sodium bicarb if my patient is not acidotic, okay? So that's not appropriate. Calcium can be appropriate in a code for specific reasons that I don't remember right now, but it's not it's in the code card, but it's not commonly given with every code. It is patient specific. She said the lung sounds had rails bibasilar.
Oh, that's 100 ml bolus being administered at a controlled rate.
Thank you.
Still having a hard time ventilating the patient.
Capnography is continuing to decrease. Waveform is flat.
Brian, can you reposition the airway? Nancy, can you take a quick lesson?
So that capnography that they're talking about, that's their end tidal CO2. Okay? So they can give MAG, especially if your patient is in torsades. Torsades has an indication for magnesium to smooth the muscle. You're welcome. They're saying they have a decreased capnography, which means the CO2 detector, end tidal CO2 numbers are dropping, which means they're not getting adequate ventilation. So she's saying, I need you to reposition and assess your airway because you're not ventilating well.
Listen to breath sounds. I do not have pulses with compressions. Kirsten, can you hold on to compressions for a second, please?
Back. Back. Yeah, I have decreased breath sounds on the left.
Okay, let's just go ahead. I need a 14 gauge needle. I think this guy's gonna needs needle decompression immediately. Everybody quiet, please.
So what do we think is happening? He's either having a pneumothorax or a hemothorax. Okay? She wants to do a needle decompression because she's thinking that it's going to be just a pneumo that could turn into a tension because remember his chest is closed. Okay? So we're hearing decreased breath sounds. If it was a tension pneumothorax, what's happening to the heart? It's being shoved and smushed. So it looks like they're on his right side. So if it's a tension, the lungs and the heart are getting shoved to the left side, right? So you would see that deviated trachea with the mediastinal shift, meaning the whole heart is being displaced, which can cause arrhythmias. All right. So is that what happened in the first place? Maybe. I mean, he was complaining of a lot of pain, right? But he was just post-op of abdominal surgery. Was it radiating from his chest into his abdomen that he thought that it was abdominal pain, but really it was because he had a collapsed lung? And now he arrested because his heart was being pushed on by the tension, right? So now she needs to do a needle decompression to be able to relieve the air pressure.
Brian, bad patient?
Much better.
Much better, good. Nancy, would you prepare a chest tube drainage system, please? Yep. Number 32.
I have an organized rhythm on the monitor. Here's bradycardic.
Do we have...
Our capnography is improving.
Excellent. Okay, so capnography is coming up. Better. Could you check see your carotid pulse, please?
Capnography is now 50.
Okay.
So the patient had a pneumothorax. They have done a needle decompression, which has relieved pressure off of the heart. They have achieved ROSC, okay? And it's bradycardic. It sucks a little bit. Now she needs to make sure that this is not PEA, which is when she tells them, can you check for a carotid pulse? And she's already planning to put a chest tube in because the patient has tension pneumo. I need to put a chest tube in, okay?
Let's go ahead and get that chest tube ready. Let's go ahead, sir. John. John? He's not responding. Is he making any effort to breathe, Brian?
Not at all.
Okay, let's go ahead and ready our airway equipment. We're going to intubate this patient. Can we get a set of vital signs on him? Kirsten, could you give me a set of vitals, please? And let's go ahead and get the 12 lead. He remains bradycardic, so I'm a little concerned.
So I don't see a P wave, right? I have a QRS, I have a T, it's bradycardia. We do have a pulse that is palpable, but there's no P wave. So something here is not, it's not going well, right? If we leave this patient without any more intervention, he's gonna code again. And by the way, I'm surprised they didn't already establish an artificial airway, that they're waiting until now to start an artificial airway, which whatever, you do you. But usually that call is made way before this.
Concerned about that. Brian, you're not having any trouble ventilating him, are you?
No, it's still ventilating pretty well.
Okay.
12 lead.
Okay, this patient's having a STEMI. He needs to, we need to get him ready to go to the cath lab. We can do PCI with therapeutic hypothermia. Can we get a BIS monitor reading before we apply therapeutic hypothermia on this patient, please?
Has anybody ever heard about therapeutic hypothermia?
We read about it.
Yes.
It's a drug related.
Okay, so therapeutic hypothermia has shown a lot of evidence that it is tissue protective for the heart and the rest of the body and brain. Okay, so it gives the body a way to heal and relax over a 72-hour period. Is it 3? Or is it 24? It's 3. It's 3. It's a 72-hour period. There are 2 ways to cool a patient. You can do it through a transducer, which is a very large access point in the groin where you can inflow cold saline, and it will be a circulating flow of cold fluid that will bring the patient's temperature down, and I'm talking to like 92. Okay. Or you have things that you actually attach to the person's body. So there's these big, huge pads, and they have different shapes. There's one shaped for the leg, shaped for the other leg, shaped for the abdomen, for the chest. And they're very sticky. They stick to the patient and they circulate cold fluid all throughout the pads, and that cools the patient. Okay. Is it 24? So you cool the patient for 24, and then you have to be very careful when you rewarm them. You can have a lot of electrolyte disturbances while you're rewarming a patient. And then I know there's 72 hours somewhere. You should wait 72 hours after hypothermia treatment to figure out if the patient is going to be successful or not.
He's having a STEMI.
Okay.
Good call, Heather.
Thank you.
Test tube's ready when you're ready.
The cath lab has been activated.
Excellent. Team, great job recognizing that patient was in trouble and calling the RRT in the code blue and getting him to the cath lab. Excellent, excellent teamwork. How did y'all feel about it? How did you feel that code went? Heather?
I thought it went good. I thought we had a little bit of a delay starting compressions after the first shock and getting the board underneath.
Okay, sometimes that is an issue, but it is very important that the board is placed under the patient. You cannot give an effective compression on a mattress, so I'm glad that you guys recognize that and got the board under the patient. Kirsten, how did you feel? Have you ever been involved with a real code before?
No, I have not, but I think it went pretty well.
Okay. Did you know what your role would be in a code?
Good CPR. Exactly what you need to do.
Good CPR. That's absolutely right. Thank you, Mike. How did you feel about the monitor? Did you have any issues with monitoring the patient?
Nope, I think everything went well. We got the capnography hooked up really, really quick. Providing feedback from the capnography on the changes in status of the patient.
You did a great job doing that, because that's what determined that this patient actually was suffering from a tension pneumo from us ventilating him too vigorously. But he was also having a heart attack on top of that. But it could have been a number of different things because he's a fresh post-op. So be thinking about those H's and the T's when the patient does arrest. Whitney, did you have any difficulty with the medication administration?
No, it was great that you were able to give me a heads up on what meds you wanted me to prepare ahead of time to give me extra time. And I also thought that as a team, we had great closed loop communication.
Excellent. I did that. I recognize that as well. Everybody made eye contact. You repeated back any order that was given. How did my compressors and ventilators feel? Brian, did you realize that you were getting fatigued?
I think everything went well, but just identifying that I was slowing down because of fatigue, I could have done that a little earlier.
Yep, and Mike recognized the capnography was dropping, so that's the responsibility of the person who's actually monitoring the patient to let us know that that's happening, okay? Because it is a team effort in this. And our 2 other physicians that arrived.
From an overall perspective, I think it all looked well. Everyone seemed to know what they were supposed to be doing.
Okay. And in a code, because you guys may not be aware of this, there is one team captain. Okay, so it's fine that you come in and offer some suggestions, but neither one of those medications were indicated in this arrest. So I do appreciate your input, but when the Code Blue team is here, the Code Blue team is going to take care of the patient.
When the large group of people came running in the room, it got really, really noisy, but the patient's nurse, Heather,
She said, I'm in charge and I'm going to put you in your place in front of all of these people. Okay, so some takeaways from this experience.
That was
Real strip?
yes.
No, that was not a STEMI. There was no ST elevation. That was not a STEMI. And we didn't even look at ST elevation, STEMI or non-STEMI.
Well, I had.
So, well, yeah, but
Not.
yeah. Yeah. Well, I wouldn't test you on a STEMI or non-STEMI if I didn't teach you about it. Yes. So they don't normally count respirations, they count compressions. I did hear her, but she was quiet. So that communication, we heard the physician say it, that's called closed loop communication. So that means that I'm saying something to you, you're repeating it back to me because I know you heard me. Okay? This is very important in nursing, especially in an emergency situation, where and I've told physicians this, if you didn't hear me say it back to you, that means I did not hear you. Because it is my job as a nurse to verbally repeat back to your orders. So if you're saying to me, I want XYZ, I am going to look at you and say, XYZ heard, and I'm going to go perform that duty. But if I do not repeat that back to me, and they are trained also to know that if you don't say that back to them, they're going to look at you again and be like, did you hear my order? Yes, sir, I did. Yes, ma'am, I did. And I'm going to repeat it back to you because that is safe protocol. Okay. Any other feedback? The leader did do a good job. She was clear, for sure.
Very straightforward.
She was straightforward. She was by the book. She was very like, this is my code. I'm running it. I know what I'm doing. And that's the way it should be. It's an organized chaos. Online, what do you guys think? Has anybody, I know some of my EMT people have obviously been in a cardiac arrest. You've probably have history with a Lucas. I hate that thing. You probably have history with giving medications like that, but any other people, have you been in a code? Have you ever seen this before?
I've been in quite a few.
Mhm.
I will say I've had like one code that was an absolute shit show and like sorry. But like
And you
there
never
was like
forget it.
No, it was like honestly traumatizing.
Yes.
And aside from that one, I've never seen one that bad actually.
I've only been in one really, really bad one and I've never seen it again and I hope to God I never do.
Yeah.
Sharia,
Like-
what were you gonna say?
I actually experienced 2 codes that I was involved in. It wasn't as efficient as a nursing home. We don't have like a team lead and a whole group of people. It's just, everybody just come running to the code. So
Yeah.
it wasn't as efficient as this, but the patient, one of them did live. So
Good.
Yeah.
Kelsey, did you have something you wanted to add?
No, not really. I mean,
That's okay. I just didn't want to cut you
I
off.
work in a hospital, so like we don't see codes happen like that. Like when we call a code, I mean, if we had called a code, like by the time that patient actually coded, if we had called a rapid, the entire code team would have already been there. by the
Yes.
time that man even coded.
Which is why, and I have written papers about how important it is for nurse recognition of the symptoms that are happening, early recognition, and calling that RRT when you need to call it. Because when you call that RRT and that patient does code, you already have your team there. So early recognition is so important. You should never, ever be embarrassed or hold back from calling an RRT, ever. Within the Mercy Health system, they were one of the very first hospitals that came up with rapid responses, I believe like 20 years ago. And there's been a ton of evidence-based practice since. It is very encouraged in those hospital systems to call an RRT when necessary. Because the worst thing that could happen is that they come there and be like, oh, your patient, they're okay, we're gonna do this or that, and then they leave, right? But I have also been teaching clinical at another hospital where they will do everything under the sun before calling an RRT, which is so frustrating. Why are you calling a provider and waiting 20 minutes for them to get back to you when you could have called an RRT, had a provider at your bedside, and been taking adequate care of this patient? So if you find yourself in a situation where you're working at a hospital like that, where it's frowned upon to call an RRT, please do not fall under that web of silliness, okay? Because it's not about you. It's about your patient and their life. So I don't think I just think that's shitty. That's my opinion.
We had a code, my first one that I was in. Our patient had congestive heart failure and he was actually discharged, but we were getting him dressed and you could hear the hood. And we're like, or me and the nurse were looking at each other and we're like, I don't think he needs to go. And he coded 5 minutes later, like, well, if we were still in the room to start the code. And he ended up coming out of it, like he made it through it. But
Yeah,
it was,
achieved ROSC.
yes.
Yes, he achieved ROSC. Okay. Any questions? So takeaways from this situation and talking about ACLS. Epi is given how often? 3 to 5 minutes. Amiodarone can be given how many times? Twice. The first dose is how much? 300 milligrams. The second dose is 150. We give it in between. Epi. We have 2 pulseless defibrillated shockable rhythms. Ventricular fibrillation and pulseless VTAC. If you have a patient that has coded and they are in PEA, which is pulseless electrical activity, or asystole, that is not a shockable rhythm. Okay? Your CPR must be adequate, meaning you have to have adequate depth and recoil. Okay? You should switch out CPR providers every 2 minutes. If that person needs to be replaced earlier than that, that must be spoken out loud. Everything in a code in ACLS must be spoken out loud in that closed loop communication. It is imperative. It is very important. If you are a person that is part of this and you do not adequately communicate, your team members are going to come to you and say, hey, you have to talk to us. You did not participate the way that you needed to participate, and you need to speak out loud while you're compressing and while you're doing your role. Okay? This is called a debrief. This is very common after a code once all the dust has settled. If it's on a unit, it usually doesn't happen with the leader of the code because they're already on their way to the unit. They have their patient, all your code members and your team members, that patient's nurse, they have all left and they're going down to the ICU to get this patient stabilized in the unit. This usually happens after all the dust has settled, the patient is stable, your nurse manager comes out and they're like, okay guys, let's talk. Let's have a debrief. Because a lot of people have a lot of feelings after a code. They think about every single step after it's all said and done. They think about it over and over and over and over again. What did I do? Did I do this okay? Did I delay? Did I do anything wrong? Did I not push it fast enough? Was my CPR okay? I can't believe I just felt this person's ribs break under my hands. I cannot believe that just happened. My patient was fine 1 second and the next second he was gone. I can't believe this happened. I walked into my room, my patient's gray, and all of a sudden there's no pulse. Holy shit. Okay? It's trauma. And we need to be able to cope and talk to each other and debrief about that trauma so that we can pick ourselves back up and deliver care to that next patient. Okay.
Mrs. Simmons. So one of the questions earlier in the chat was, when the EMTs arrive, do they pick up your CPR count or do they start a new count? Like when my grandmother, they picked up from my count.
Time out. You got to start over. You cut out. I didn't hear anything you said.
Oh, okay. So one of the questions was, like, when EMTs arrive, like, let's say you're performing a code outside of a hospital. Like, I was giving CPR to my grandmother, and when the EMTs finally arrived, they took over my count.
Yes.
But I don't know if that's standard, because I was fatigued. I was doing it for 7 minutes. So, like, by the time they got there, like, I was cooked. I was done for.
Yeah.
Is that standard for them to take over your count, or do they start a new round of 30?
No, they should take over your count from where you left off.
Okay, thank you.
Yeah. Yeah. Because you're still in the middle, you're in the middle of a cycle. They should take over your cycle. Yeah. Good question. Any other questions? ACLS, compressions, medical management.
Oh, I do have a question.
Yeah.
So we mentioned that ACLS certified the team members, they like crack open the epi.
Yes.
So if we're doing BLS, so say we're not ACLS certified, is it strictly compressions at that point? And then when they come in, I think I'm just confused on, like, are we able to push epi? Like, if we're in the code?
That is a really, really good question. And this is why I am writing my dissertation for my master's on why I believe that all nurses in a hospital system should be ACLS certified. Because it provides a delay in care. Every nurse on every unit should have the same learning opportunities and have the same preparation. Maybe they don't do it every day. Maybe they don't do it once a month, once a year. But at least they've been a part of a mock code and they have had the education and interpretation of ACLS. Are BLS providers allowed to give epinephrine before the code team starts? I do not know that answer, and I'm going to look it up. Silly question, but out in the field, away from the hospital, can you hit someone with an EpiPen if they go into arrest? That is a great question. That is a really, really good question. Now, I will say, if you were like a Good Samaritan, because we have Good Samaritan laws, that if you are just some Joe Schmo and you start CPR on the side of the road, we have laws that protect that person. That is the initiator of the CPR. That is a Good Samaritan law. I cannot prosecute you for anything because you tried to save that person's life and say nothing happened, you didn't get the help you needed, you fatigued out, you burn out. Hey, I did all I could, right? That protects that person. That is a good question. So here's the thing. When you give epinephrine during a code, you're giving it IV. So are we saying, like, are you going to like stab the person in the chest with their EpiPen? Like,
Because it's got to go through muscle.
it would be muscular. It would be intramuscular. Would it be helpful? I mean, any epinephrine given, I keep it in my first aid bag, but never knew if I could use it. I'll tell you what, the person's dead and it's not going to hurt him. I'll tell you that right now. Now, is that NCLEX appropriate? I don't know the answer to that, but I'm telling you, if I was out in the wild and I was performing CPR and I knew that my ambulance wasn't going to be there for a hot minute and the person says, I have an EpiPen, give it hell, girl. Give it hell. Because this person's already dead. I have no pulse. I'm giving compressions until my life gives, until I can't anymore. So it's not going to make him deader. You can? Where?
Yes, and EpiPen can
can be used if someone is in cardiac arrest and coding.
Does it say like in the chest?
Doesn't say where.
Okay. So either way, she said, hell yeah, I pray I never need to. That is a great question. Thank you for asking that. I have an EpiPen for Henry, even though he's not anaphylactic to anything because I have anxiety. Hi, it's me.
I've never
Jessica,
Yeah.
off of the ACLS, I know at least where I work, even if you have it, if you're not in ICU or a step down nurse, you still can't practice it. So I think it depends on where you work, because even if you have it, if you're just a med-surg nurse, you cannot give it.
Okay, interesting.
Yeah, because I was just asking somebody about that, about the ALS. Actually, I was asking somebody at work.
About the ACLS?
Yes, and they said that med-surg nurses they're not required. Because I said, why?
Yes.
I said, why don't you pay for it?
We were just talking about that.
So that,
Yeah, we were talking about. So Lisa and I were talking the other day, and we were talking about, you know, if you're a med-surg nurse and you're only BLS certified, like so in a way it protects you. As a med-surg nurse with only a BLS certification, it protects you so that someone can't come up to you and say, why didn't you do this? Why didn't you give epi? Why didn't you give an artificial airway? Why didn't you get an ABG? Why didn't you blah, 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 blah? And you can say, as a BLS contributor, I am certified in basic life support. I am not required to give life-saving medications. So in a way, it covers your butt so that if you were to do something wrong or whatever, that cannot be held against you. So I guess, I think if you thought about it the other way around, it would also be, if you're not trained for this, then don't do it.
that's what happened. She asked,
Yeah.
was I going to get my ACLS when I graduate? That is what
I believe you should. I believe all of you should. 100%. If you are hired onto a tele step down ICU, not only do you have to pass an arrhythmia exam. Oh yeah. I had to pass an arrhythmia exam when I got hired on PIC, 4th floor, St. E's, Maine. And within 6 months, I was required to have my ACLS within 6 months because I was a new grad. And I'll tell you what, when I was a new grad, I wasn't ready. I didn't know. I'd never seen a code. I wasn't ready to be ACLS certified. I needed that 6 months, get my feet wet.
Yeah,
You know, I was too green. You have to do it for labor and delivery too. I believe that, yes, because a lot of, well, hopefully, knock on wood, not a lot of emergencies, but emergencies do happen in labor and delivery. So that is a huge specialty. Also, the OR, you have to be ACLS certified. Cardiac cath lab, IR, all of those nurses have to have ACLS because when shit goes down, you are your team and you better carry the weight of your team until somebody else comes to help you. Especially labor and delivery, they truly are their own team. Now, Brittany, correct me if I'm wrong. You start coding with each other, ACLS, you are able to do all the things. Do you have a code team arrive or is your labor and delivery physician your code team?
It's our own.
No, so we still call the code, and the reason being our labor and delivery, typically our codes happen in the OR. Our physician is working on getting the patient put back together, and our emergency room physician is working with anesthesia to run the code and get all of the like airway secure.
It's a team effort from both sides. Which hospital do you work at?
St. Joe's Warren.
Okay. Which hospital do you work at? Mercy Canton.
Like with a lot of different stuff, like we do teams deliveries where respiratory's already in the room while they're delivering.
Yeah.
And we do the OBERT, which they just started this, but it's like our own code.
Is Mercy Canton a level 1 or level 2?
It's a level 2.
It's a level 2. Okay.
We don't have a level
But
trauma center.
Akron General is, in Canton.
Yeah, in Canton.
Akron General and SUMA are both level 1.
Extend out.
And so is Children's.
it shocks, yes, don't need nurses.
up there are not PAL certified.
So when I think it was Brittany that brought it up about the NRP, PALS certification is less likely in OB than it is for the neonatal resuscitation, because neonatal resuscitation versus PALS is two very different things.
Yeah.
So I need a break. I gotta pee. Amy, my question was pertaining to out of the hospital, Good Samaritan gesture in the hospital. You need the doctor's order. Yeah. Yeah. All right, let's take a break. 10 minutes. I gotta pee. Are we here 2:30 or 3:30? Shit.
A long day.
All right, 10 minutes.
All right. I don't know when was 10 minutes. Has it been 10 minutes?
Probably.
I don't know. Nobody's back online.
I'm here, but I'm having stomach issues, so I'm gonna keep my camera off.
That's fine. Has it been 10 minutes? We only have one more hour. All right, we're gonna get started with Shaw. I did. So, Shaw, what is it? Oh, there we go. No?
Yeah.
Oh, because it's on this computer. I'm confused. Oh, get out of here.
Ms. Simmons,
Yeah.
I'm sorry, just real quick, the question I had about the doing the medications, I meant like if you were on a med surge unit, would they just already have it like a protocol where you would give them? That's what I was asking.
No, we covered both. No, if you are a BLS provider, then you are not giving epi on the unit. You have to be HLS certified. All right. So, shock. What is it? Shock is a condition in which tissue perfusion is inadequate to deliver oxygen and nutrients to support vital organs and cellular of it. Okay. So the pathophysiology is that tissue perfusion is determined by cardiac output. We've covered this in many ways, many times. This helps determine the stroke rate and the resistance to the heart. The primary pathophysiology is determined by the underlying shock state. So is it cardiogenic shock? Is it hypovolemic shock, obstructive, distributed, neurogenic, or septic? There are initial stages of shock, four stages of shock. The first initial stage is that the cardiac output is decreased enough to cause the tissue to become hypoxic.
The cells go from aerobic, meaning they are using oxygen, to anaerobic, meaning they're functioning without oxygen. Acidosis. That's why your lactic goes up when your patient is going into shock. Okay, so your normal lactate is what is that, less than 1? And then lactic acidosis, which would also be metabolic acidosis, it would lead to signs of metabolic acidosis, is a lactic greater than 4. So our body is always going to try to compensate. The sympathetic nervous system shunts blood to vital organs through vasoconstriction and microcirculation of vessels. So instead of your fingers and toes getting all this oxygen-rich blood, it is shunting that blood to the core, to your vital organs, your heart, your lungs, your kidneys, okay? So it increases the perfusion to your heart and brain. Oh, I forgot brain. Heart and brain, where at first you're going to see a higher heart rate and a higher blood pressure because it's trying everything it can to perfuse with oxygen, okay? And then it decreases perfusion to the GI, the skin, and the lungs. So our GI, I'm not worried about pooping right now, okay? I'm not worried about peristalsis, I'm dying. I don't care about my intestines. My urine output is low, which you would think that when we talk about vital organs, which I actually just said that and I shouldn't have said it that way. When we talk about vital organs, we think that renal and lungs would be included in that, right? Well, apparently they're not important as the heart and brain, which makes sense. We can survive without a kidney for a while. Can't really survive without a lung, but definitely can't survive without a brain or a heart, okay? So the urine output goes down because of decreased renal perfusion. You get cold and clammy skin because of the decreased perfusion within the extremities. And then you have a higher respiratory rate because your brain is trying to get more oxygen with every breath. So then we go to the progressive stage where the body's rescue attempt, that compensation, is failing. The compensation can no longer occur. So decreased perfusion happens to vital and non-vital. So we have decreased perfusion to the heart, to the brain, and then all the rest, to the kidneys, to the lungs, to the GI, everything. This is when you're going to see severely altered level of consciousness. Your body is still trying to get more oxygen, so you will see tachypnea still here, but they will be hypoxic, okay? And at this stage, the progressive stage, we are most likely going to need intubation. The blood pressure is low, okay? This is where we have severe hypotension. Our temperature is decreased. When we see hypothermia, that is a bad sign. If the hypothermia isn't caused from being outside in the very, very cold, and you're just hypothermic just because, that is a bad sign, okay? Increased risk of GI ulcers strictly because of the stress on the body and the cortisol production, and increased risk of bleeding. You guys learned about DIC in OB. This is when you literally clot and throw out all of your clotting factors all at once, and your blood can no longer clot on its own. And it's very, very scary, especially for a laboring mom. But this can be a part of that progressive stage of shock, especially if it's hemorrhagic, okay? And then number 4 is refractory. This is the terminal phase, and this is where we have irreversible consequences. There is absolutely nothing being compensated. Your organs are shutting down, hanging on by a thread, and death is inevitable, okay? know when you're ready.
Is there any getting anybody back from stage 4, or are they just goner at that point?
So in stage 4, this is when you're probably, if it's respiratory, or, you know, leading from sepsis, your patient is in like critical ARDS. If it's sepsis, your patient's kidneys, they're not functioning whatsoever. And then we have a Hail Mary called CRRT, which is continuous renal reperfusion therapy, which is just another fancy way of saying continuous dialysis. And it's very, very intense. It's a 1-to-1 with an ICU nurse that is certified in CRRT. And that truly is a Hail Mary at the end here. Okay. So types of shock, we have a couple different types. We have hypovolemic, which includes hemorrhaging. Because truly, when you hemorrhage, you're losing fluid causing hypovolemia. That hypovolemia is just occurring because of blood loss. Okay? Cardiogenic shock, which means it's happening from the heart. It is cardiac oriented. Obstructive shock. And then we have a whole separate category called disruptive shock. So with disruptive, that includes 3 things: septic, anaphylactic, and neurogenic. So disruptive shock is its own category. And the reason that it is its own category, because if you look back here, it says in the compensated stage, you have an increased heart rate and an increased blood pressure, right? When it comes to disruptive shock, which is septic, anaphylactic, and neurogenic, you see massive hypotension caused by vasodilation. Okay? There is no hypertension that's trying to compensate. These types of shock are causing massive vasodilation, which is causing severe hypotension. That is important for you to know. So for hypovolemic shock, this is due to insufficient circulating blood volume, which is the most common type of shock. So this can happen from hemorrhage, of course, which is an external fluid loss, trauma, which can also leading to hemorrhage, right? Postpartum hemorrhage. So we're just listing types of hemorrhage, okay? Vomiting and diarrhea. We're talking extreme vomiting and diarrhea, extreme dehydration. Diabetes insipidus. Remember when we talked about diabetes insipidus, the patient is putting out up to 20 liters of urine a day, which is impossible, by the way, with what you have in your body. That's why they drink fluids like they're going to die, because they're so incredibly dehydrated that they have to put the fluid back in just to dump it right back out. Okay? Your non-hemorrhagic fluid shift that could result in hypovolemia would be burns. Again, severe dehydration, which I mean really is just tied into DI, because DI is not hemorrhagic. It really shouldn't be under there. And then internal bleeding. So it's hemorrhaging, but it's not external. It's inside the body. Okay. So, and why burns? We're going to talk about burns. But just to give you a little tidbit is that if your body is severely burned, your skin is what keeps everything inside, right? So when you burn your skin off, what happens is that the fluid in your body evaporates and you are at a huge risk of dehydration when you have significant burns, okay? Because the skin isn't holding it in anymore. Your container has a big hole and all your contents are leaking out and evaporating, okay? So symptoms of hypovolemia, and especially at the top here, I want you to pay attention to that top where the colors are. You have a decreased cardiac output, decreased blood pressure, because when you at first, you're going to try to vasoconstrict and that's your compensatory mechanism, right? It's always going to try really hard to vasoconstrict and increase that blood pressure. But if all of your blood is falling out of your body, it doesn't matter how much vasoconstriction you have. When it comes to massive blood loss and you have no contents, your blood pressure is going to go down, okay? Decreased oxygenation, because our blood carries oxygen. And if we don't have blood, we don't have oxygen. Decreased urinary output. Our kidneys are not being perfused. No, they're not. Increased systemic vascular resistance. We're going to talk about that in a second. And increased heart rate because your body's trying to compensate. Okay. So your patient is going to be symptomatic. They're going to be short of breath, pale and cool because all the blood is being shunted to the core, or it's being lost while it's being shunted, right? Altered level of consciousness from the decreased oxygenation to your brain. Tachypnea because your brain is saying, breathe faster, breathe more. I need more oxygen. Weak and thready pulse because I can't sustain. I'm the heart. I can't sustain this low amount of volume. So the immediate response to hypovolemia, unless, by the way, this is a like hemorrhaging head wound, because you don't want to put somebody on their head if they're bleeding out of their head, okay? But if we're having massive blood loss, Trendelenburg will help you because it's going to cause the blood to go to the brain, which is causing your blood or your brain to be oxygenated. Replace volume as fast as possible. So not only are we giving saline and LR, but if we're losing a massive amount of red blood cells, there's only so much you can lose. You have to replace them. So either you're having transfusions or we're calling this a trauma mass transfusion. So when we talk about trauma transfusion, this is when I don't care what blood type you are. I don't have time to give you a type and screen. You're getting a massive amount of O neg, and once we have enough volume to type and screen you, we will. But we need to save your life first. Okay? It won't be my, I know.
Oh, there's a blood shortage. Did you see that?
I know. I hate you guys. They're making fun of me because I don't donate blood and I'm O negative. And it's right across the street.
It's okay. Me too. I got 3 phone calls from them yesterday.
Oh, well, I'll tell you what, at least they don't call me. And then we need to give supplemental oxygen. If this person is hemorrhaging, what, you're O neg too? Well, your baby can't donate blood. Her baby's 4 months old. She's like, yeah, my baby too. Me neither. I'm a terrible human. So, we want to give supplemental oxygen. If your patient is hemorrhaging massively, they're intubated or they're going to be intubated shortly. And replace electrolytes. This is especially important when it comes to burns, and we'll talk about that when we talk about burns. But the electrolyte and fluid shift is very important. So I mentioned systemic vascular resistance, which is the SVR. So vascular resistance is the opposition to blood flow in the circulatory system. So It's crucial for regulating blood pressure and flow to the organs. Constriction increases resistance. So if you have an increased systemic vascular resistance, that means that you're vasoconstricting. That's important. Disruptive, you're going to see that it has a decreased SVR because of the vasodilation. So increased systemic vascular resistance is vasoconstriction. Okay?
Makes sense.
Good.
They get smaller, they can't go into blood.
Yeah.
We're closing up like, stop.
Yes.
Yeah.
Okay. Cardiogenic shock. This is when the heart fails to pump correctly, leading to decreased perfusion to the body. There's enough blood, but the pump isn't pumping. Okay? So it's caused by cardiac dysfunction. And with this, again, you have a decreased cardiac output, decreased blood pressure, decreased oxygen, decreased urinary output because it's low renal perfusion, but we have an increased SVR because we're vasoconstricting. That's our compensation. And an increased heart rate, that is our compensation. So causes include heart failure and MI, myocarditis, cardiomyopathy, dysrhythmias, PEs, and you're going to have all of the symptoms of heart failure. Right and left, because when you are in cardiogenic shock, both sides of the pump are failing at this point. Okay? So your treatment is that you want to give vasopressors to increase perfusion to your core, to your heart, to your brain. You can give vasodilators because if you have crazy vasoconstriction, that can also be hurtful to the body. So if you need to increase cardiac output, you could give vasodilators. This is when it's very dependent on the patient, okay? Diuretics to decrease fluid buildup so that it's easier on the heart to pump. It doesn't have so much fluid to pump. Inotropes, this is where our dobutamine comes in, okay? Because it improves contractility. Remember, on that first exam, we had a question about dobutamine, and the answer was to increase urine output. And that happens because when you increase your cardiac output, you also increase your urinary output by increasing renal perfusion. But I also accepted tachycardia because it causes tachycardia. And then you could also put in an intra-aortic balloon pump, which is going to increase your cardiac output. This is a very specialized CVICU situation with specialized cardiac nurses for the balloon pump, okay? Next, we have obstructive shock. If you've noticed, they all have the same stuff at the top, those same colors. Decreased cardiac output, decreased blood pressure, decreased O2, decreased urine output, increased vasoconstriction, which is your systemic vascular resistance, and an increased heart rate because that is compensating. So this can be caused by tension pneumothorax. This is going to be caused by anything that's obstructing blood flow. So it's a mechanical obstruction that blocks heart, the heart from filling or pumping properly. So is it a tension pneumo that's putting too much pressure on the heart so that it can't fill and contract or dilate and contract properly? A PE, it's not allowing that blood flow and oxygenation, it's obstructive. Cardiac tamponade, remember that's fluid that is in the pericardial sac that is strangulating the heart. And eventually, if it gets so severe, the heart will stop under that strangulation because it has to be removed during a cardiac tamponade treatment. Pericardial centesis or pericardial window, yes. Vena cava syndrome.
I actually don't know what that is, but I'm thinking that it's a blockage in the vena cava, and that sounds scary. It sounds scary. Blocked.
All over, like it is. Yeah.
So then we have severe pulmonary hypertension. So when we talked about PAH, pulmonary arterial hypertension, restrictive cardiomyopathy. Remember, restrictive is when those walls are rigid, they don't want to move. Okay, it's not overgrowth, that's hypertrophy. Restrictive is when it doesn't want to move and expand or dilate and contract. And then pericarditis. We have very similar symptoms to our previous shock and the one before. Okay. With treatment, you need to treat the underlying cause. If it's caused by a tension pneumo, we need to decompress and put in a chest tube. If it's a cardiac tamponade, we need a pericardiocentesis. If it's a PE, we need to either remove that PE by a thrombectomy, or we need to give the patient heparin and thrombolytics, like your ECOS catheter that we talked about. And then if necessary, volume resuscitation with either blood products if they need it, or your saline and LR. Okay. We have now gotten to our disruptive shock. So now, this is different. These are different. This is a severe reaction to an allergen that causes a release of histamine. That histamine causes vasodilation and bronchoconstriction. Okay? This can be caused by an anaphylaxis reaction to anything. Anything. Food, meds, bees, bugs, snakes, rabbit, I don't know, rabbits. I'm sure somebody's allergic to a rabbit. Latex. This is anaphylactic shock. Contrast dye. That's I mean, not super common, but it's common enough. Okay. Our symptoms are going to include decreased blood pressure because of massive vasodilation. Increased heart rate because we're trying to compensate. Decreased oxygenation, not only because of the vasodilation and the decreased cardiac output, but also because of the bronchoconstriction. Our airway is being cut off. Okay? Decreased cardiac output, decreased SVR. So if we looked at our previous slide, all of our blue ones are down. We have two that are up, right? Cardiac output is down, blood pressure is down, O2 is down, urinary output is down, SVR is up, heart rate is up. Whoop. Here, we only have one thing going up. My blood pressure is down, my oxygen is down, my cardiac output is down, my systemic vascular resistance is down, which means vasodilation. The only compensation I have, which by the way, isn't going to work, is my tachycardia. Because when my airway closes, I am then going to go into respiratory arrest, which is then going to lead to cardiac arrest. But with this vasodilation, there is no tissue perfusion. The blood can't get to where it's supposed to go. It's just running through a garden hose with no pressure versus a straw that has a lot of pressure. Okay? And we also know with allergies, we can have itching, hives, flushed skin is from the vasodilation. Paleness is going to come from hypoxia. So at first you're going to see the flushing with vasodilation, but the more your airway is cut off, the paler you will become because there is no oxygen. Wheezing and dyspnea, obviously from bronchoconstriction. A swollen tongue or throat, this is your angioedema, your massive swelling of the airway. And then nausea, vomiting, and diarrhea. The treatment, we should always remove the causative agent. If it's something that you put on your body, get it off your body. Okay? We need epinephrine. This is why patients that have a history of anaphylaxis must carry an EpiPen at all times, because this will counteract the massive vasodilation. Okay? Oxygen and maintain airway. Severe swelling may cause the need for an emergent tracheostomy. This is so valid and so scary. We also can refer to this as an emergency crike. And what's crazy is that I have literally planned out in my head in so many times how I would do an emergency crike on my kid if he had an anaphylactic reaction. Would I use a pen? Would I use a straw? Would I use it? Like, I'm not kidding. I am that crazy.
So is anaphylaxis the same as anaphylactic shock, or does anaphylaxis lead to anaphylactic shock?
Anaphylaxis leads very, very quickly to anaphylactic shock, because the act of anaphylaxis is the vasodilation and the histamine response. The histamine is what causes it. So when you have a reaction, an anaphylactic reaction, it is caused by a massive histamine release. That histamine release then causes your inflammatory cascade, okay? When you have that inflammatory cascade, I'm not going to get too deep in it, but you have cytokine release, you have this massive inflammatory release with the histamine. That is going to cause massive swelling of the soft tissue. Then with anaphylaxis, that histamine causes vasodilation, okay? And bronchoconstriction all at the same time. It's all happening rapidly. Okay. She said that's something I think about too. It's called having anxiety. Amen, Emma. Well, I'm glad we're part of the same club. Your medications are going to include antihistamines to lower the immune response, albuterol to bronchodilate, corticosteroids to decrease the inflammatory response, and then IV fluids to hopefully try to add volume to try to help the massive vasodilation. The epinephrine is going to vasoconstrict. It's only doing so much. So by the way, if you didn't know, if anyone ever has to use an EpiPen, you have to go to the ER. You can't just use an EpiPen and then all of a sudden you can breathe and then you're like, I'm cool. Because guess what? Epi has a very short half-life. So there is a huge risk for a reaction, an anaphylaxis reaction to occur again after you have already treated them with Epi. Okay? So if a patient ever has to use Epi, Chelsea says, yes, I teach it. Oh my God, I feel like we always have to tell people this. You do. You do have to tell people this. This is where patient education is huge, because people really think they're like, oh, I'm just going to give myself a shot of Epi and I'll be fine. No, ma'am. They must be taught they have to go to the ER. Okay. Our second type of disruptive shock is neurogenic. This is where there is central nervous system damage leading to loss of communication between the sympathetic nervous system and blood vessels that it controls. So this can be caused by spinal cord injury, trauma above T6. Remember, we talked about autonomic dysreflexia. We talked about neurogenic shock. So this can also happen from spinal anesthesia, CNS damage like meningitis, cerebral ischemia like a stroke, and Guillain-Barré syndrome. Have you guys learned about Guillain-Barré? From TikTok, she said.
Taking care of a couple people with
Guillain-Barré is a neurological disorder that is reversible. It is similar to ALS. Some people call it Lou Gehrig's disease. It is similar to ALS, except ALS is irreversible. It is very scary. It's a very scary disease. So GBS, Guillain-Barré, is something that can happen to you after a viral illness, after a vaccine, after an immense amount of stress. It happens where there is a disconnection between that CNS and those blood vessels, and you get descending paralysis. Okay. So all of a sudden, you have just lost complete function of your body. These patients at their worst will need to be intubated with mechanical ventilation. I mean, all the support. Okay. And then eventually they slowly, very, very, very slowly is reversible if they're lucky enough and they survive the acute stage. Okay. And these are the people that have to relearn how to walk and talk and eat and drink. It's a really scary and devastating disease. Symptoms for neurogenic shock is decreased blood pressure, decreased heart rate, decreased cardiac output, and decreased systemic vascular resistance, which again is vasodilation. We have warm, dry extremities and a cool body. We have decreased urine output, altered level of consciousness, hypothermia. And the treatment is going to be to keep the spine immobilized. We want to increase tissue perfusion, so we want to give fluids, but we want to be careful that we don't fluid overload people and send them into flash pulmonary edema. Okay? And vasopressors most likely is going to be a very key player, especially if the fluids do not increase the blood pressure. Atropine for bradycardia, because at this point, remember, the atropine is for symptomatic bradycardia. This patient is symptomatic. And DVT prophylaxis, because whenever we are immobile, the blood is pooling, and we need to prevent blood clots. Okay. Questions so far? Okay. Next is going to be sepsis. Sepsis is huge. Sepsis recognition is going to be a part of everyday life as a nurse. This is severe and systemic response to an infection that can lead to decreased tissue perfusion and organ damage. Your recognizing sepsis symptoms are going to be temperature. Your patient is going to be febrile, or in the very odd chance, they're hypothermic. And that usually happens when they're really, really, really sick, very septic. Signs of infection. So where is the sepsis occurring? If it's from a post-op, you're going to have signs of infections at the operative area. Okay. If it's urinary, there's going to be symptoms of a UTI or even progressive pyelonephritis. The mental decline, this is new confusion or lethargy. We see this a lot with our old people that are having UTIs. They can go septic within 24 hours of the onset of a UTI. It's crazy. Extremely ill, which can be severe pain, discomfort, or dyspnea. One thing that this is forgetting that is very important is tachycardia. Tachycardia is one of your first signs of sepsis. Because remember, what happens when you have a fever? You are tachycardic. Tachycardia is a cardinal sign of infection and fever. So, SIRS, this is called systemic inflammatory response syndrome. In the hospital, we have this thing that comes up and it flags and it says, your patient has hit 3 out of the 5, blah, 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 for the SIRS criteria. Okay, it's part of EPIC. It's a management, thing, so we don't miss these signs and symptoms. So any 2 or more symptoms are going to meet the sepsis criteria. So if you have an increased temperature greater than 100.4 or less than 90, what does that say? 96.8. 96.8. A respiratory rate greater than 20. Heart rate greater than 90. And then white blood cell count either higher than 12,000 or less than 4,000. These are the signs for the SIRS criteria. SIRS, I don't know how to say it.
Wouldn't the heart rate of 90? That's
Greater than 90. Agreed. Yeah. I mean, I agree. I think, yeah, and you have to think about, right. So yes, tachycardia, and we characterize tachycardia for greater than 100. But it's also, you have to meet multiple of the criteria. So it's not just a heart rate greater than 90, right? And then stage 2, after meeting 2 or more, that is then leading to sepsis. If sepsis is not treated promptly at that stage, we are then going into septic shock. So it is a 3-stage situation, and it really is always going to start with the first, meeting 2 of those criteria or more, 2+. And I think that, and it depends on the facility because each facility is different, but I'm pretty sure I've also seen decreased level of consciousness on a SIRS criteria. So septic shock is also a disruptive shock, meaning that it also is vasodilation. So systemic inflammatory response due to an infectious source. Your causes can be from indwelling devices like central lines, Foley catheters, endotracheal tubes, or tracheostomies. UTI, wounds, pneumonia, invasive procedures like an OR procedure, and anyone that is immunocompromised. Your patients that are on chemo, receiving long-term steroids, that have AIDS, autoimmune diseases that are treating them with immunosuppressing drugs, patients that have organ transplantation because you have to be on immunosuppressants for the rest of your life, okay? Your early signs of sepsis is hypertension, tachycardia, tachypnea, increased cardiac output. This increase in blood pressure does not last long because remember, we have vasodilation. Vasodilation, your body says, I'm really trying to compensate. And then sepsis says, ha, 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 I don't think so. We're in septic shock and I'm going to vasodilate. So early, before you reach the shock stage, you are going to see hypertension, tachycardia, tachypnea, increased cardiac output, and then your decreased systemic vascular resistance is going to hit. Your skin is warm and flushed, and you're hyperthermic. Hypothermia is happening from fever. The warm and flushed skin is happening from the vasodilation. At your later stage, you are seeing massive hypotension. The only compensation you're having is your heart rate is trying real hard to try to get more cardiac output. Your oxygen is low, your cardiac output sucks. A Hail Mary is trying, but there's too much damage now to these arteries, and they cannot constrict. They are tired. They are sick. This is severe infection. So my skin is cool and clammy. I have decreased urinary output because of decreased renal perfusion, altered level of consciousness, and then coma. Hopefully this is a refresher. You want to get blood cultures before you initiate antibiotics. Okay. This should never be a delayed thing. You should never delay antibiotics if, oh my God, I don't have blood culture tubes in the hospital. I'm going to wait till tomorrow to initiate antibiotics because I can't get my shipment of blood culture tubes until tomorrow. Absolutely not. Okay, we're not delaying. I'm talking about getting blood cultures and then 30 seconds later hitting start on your IV pump to initiate antibiotics. Okay. We need to increase tissue perfusion. Most of your patients that are septic are dehydrated because when you have a fever, you evaporate your fluid. When you're very ill, you're not eating, you're not drinking. You are dehydrated. Part of sepsis protocol is rehydration. Okay. And then vasopressors if that fluid is ineffective of bringing up the blood pressure. We want to prevent stress ulcers, whether that is on the body or in the stomach. So early nutrition is going to help with wound healing. We need protein and amino acids. We need H2 blockers, which is your histamine, H2 blockers for your stomach, PPIs like omeprazole. And then you want to monitor your lactate. The higher your lactate, the more organ damage you have, the more acidotic you are, the higher level of shock. So after all of this, we then can lead to multiple organ dysfunction syndrome. This is severe sepsis plus all of your organs are failing. Okay. So this is when you are hypotensive despite any fluids. We need pressors at this point. Our lactate is greater than 4 after fluid resuscitation. We have respiratory failure where our patient is intubated and on a mechanical ventilator. We have an altered mental state, changed from baseline. And also think about if we have organ system failure, one of those organ systems is also going to be your renal function. Okay. We have 13 more minutes. How many more slides do we have? We don't have that many more slides. Just the case study. Okay. So Mr. McMillan is a 92-year-old male. He presents to the ED with urinary hesitancy and burning and a fever at home of a 101.6. His caregiver states that he doesn't seem like himself. What initial nursing assessment needs to be performed for Mr. McMillan? Vitals, urine culture, I agree. Yeah, a urinalysis. What was the other thing you said? So labs, including a lactate. Yeah, labs.
Whenever we did the like when I did it yesterday
Where?
at the hospital.
Really?
Yeah, I did his, well, she trying to say it because it was through the location, it was a BBG and the lactate was on there.
So with a VBG, they can run a lactate. Did you have to send it on ice?
they did. I didn't see how they sent because my guy was real bad.
So
Like, right there.
lactic acids always have to be sent on ice. They're usually in like a gray top tube. I could understand them getting a lactate off of a VBG,
Yes.
but it would not come off of an ABG.
Okay.
Interesting though. That was
Yeah.
cool. That's cool.
Like, much as we can.
What other nursing assessments need to be performed? So
Like his temp again.
yeah, you definitely need to check his temperature again. This was at home. That's a really good point. I actually missed that one. Orientation, a neurological assessment, right? So just because his caregiver says he doesn't seem like himself, okay, I probably need to investigate that a little bit more. Maybe some blood cultures, because what if he is septic? Okay. Upon further assessment, Mr. McMillan is weak, his face is flushed, his skin is warm and dry, he is oriented to person and place, but states the year is 1952. You're a little off there, my friend. His vital signs were as follows: 99/60, heart rate is 92 and regular, respiratory rate is 28, but only 93% on room air. Temp is high, 38.9. What physiologically is going on with Mr. McMillan? So let's
He's
think
septic.
about our SEERS or SIRS, however you say it, criteria.
Heart rate is above that 90.
Heart rate is above 90. He's febrile. His temperature is above 100.4. And my respirations are above 20. That means he meets 3 of the SEERS criteria. Okay. And we don't have a CBC yet, so we don't know. And remember I said altered level of consciousness is sometimes included in that. So if it was included at this hospital in their protocol, then he would have met 4. What nursing intervention should the nurse perform for Mr. McMillan? Let me change this. What would you anticipate being ordered by the provider?
Blood cultures.
Blood cultures. We already talked about a UA. Culture and
Antibiotics.
broad spectrum antibiotics, yes. After the blood culture. What did I say was one of the first things we want to do for sepsis criteria?
IV fluids.
Fluids. Yes, fluid resuscitation.
You're cutting out again.
Oh. Did it just start? Please tell me yes.
We can hear
yes.
you.
I'm back on Ross Wi-Fi. Am I back or should I switch it? I'm back? Okay.
Yeah.
So remember, fluid resuscitation is one of your first responses to sepsis protocol. Okay. So the ED provider orders the following: a CBC, BMP, ABG, lactic acid, blood cultures ⑥2. By the way, they usually always, well, not usually, they always come in a ×2. You always want to get 2 sets of blood cultures. Urine test, a urinalysis and a culture. Diagnostics, chest x-ray, a KUB, which is of the kidneys, ureters, and bladder. Nasal cannula to keep the SpO2 greater than 92%, and a 1 liter normal saline bolus ×1 now, plus 1,500 milligrams of vancomycin IV piggyback ×1 dose now. Which order should you implement first and why?
The fluids.
I was thinking saline because his oxygen is only 93 right now, and his orders for.
But when you get
I would say,
So
the antibiotic,
well,
the broad spectrum
so
now.
let's prioritize, okay?
Okay.
So as of right now, our SpO2 is 93%. We do not need supplemental oxygen per the order. So that is not first, okay? Next, do I have an IV?
I would hope so.
I don't know. They didn't tell me. So I can't give a normal saline bolus or antibiotics until I have an IV. I can start an IV, get all of my blood and one set of blood cultures all at the same time. Because my patient is currently stable. Right? I mean, yeah, we're going to turn a corner, but currently right this very second, he's stable. So in order for me to implement all of the things, I need an IV. And while I get my IV, I can get my blood work and I can get my first set of blood cultures. I can't give that vancomycin until I get blood cultures, which is why that answer was wrong. So number one, blood, IV, and one set of blood cultures. Number two, saline and fluid resuscitation and broad spectrum antibiotics. Number three, I need you to pee, sir. Is he going to pee? I don't know. Do I need to straight cath him? I don't know. I got to figure that out. So that's my next priority. Orders for a chest x-ray and a KUB. I can't do anything till they get here. So that is not at the top of my priority. And my patient also is 93% on room air and does not need supplemental oxygen per my order. Does that make sense?
So I would do blood work and then meds. I mean, blood work, urine, then meds.
Blood work, saline, meds, then figure out the urine situation. Because I don't know how he urinates. And also, by the way, I can have a conversation with my patient while I'm getting his blood work and say, hey, do you have to pee? Hey, I can look at his caregiver. When is the last time he urinated? And if he's severely altered, I'm probably just going to get an order for a straight cath. But right now, I don't have an order for that. Okay? So I need to do what I have an order for first. All right? So all blood and urine tests are completed. You initiate the fluid bolus. You are still waiting for the vancomycin to arrive from the pharmacy. You notice he is more drowsy. He is now only oriented to self and feels warm. You take another set of vital signs to find the following: 86/50, MAP of 62, which means he's not perfusing. A MAP of less than 65 means that your brain and organs are not perfusing properly. A heart rate of 108. We are tachycardic now. Temperature of 39.3. What is that? Somebody figure that out.
102.
Respiratory rate is 36. We're tachypnic. We're 88% on room air. Now we need some supplemental oxygen. Our lab results, white blood cell count is 22,000. Lactic acid is 3.6. pH 7.2, which is what?
Acidotic.
Acidotic. CO2, which is what? Of 30.
Acidotic. No, that's alkaline.
That's alkalotic, 102.7. And our bicarb is 16, which is acidotic. So this is
metabolic acidosis.
Metabolic acidosis with partial compensation. Okay. Our PO2, I've done it so many times that it's actually working in my head, which is wild. I never thought I'd get here. A PO2 of 64. What is his PF ratio?
How many liters?
He's on room air. So what is 64 divided by 0.21?
305.
305, 304. Round to the whole number. Which is negligible. It doesn't make a difference between 304 or 305, right?
305. It's 304.7, so 305.
Okay. So our PF ratio is 305, which means he is hypoxic, right? And we need supplemental oxygen. We have metabolic acidosis, which we already know because his lactic acid is 3.6. Okay. And of course, our CO2 is going to be alkaline because his respiratory rate's 28. He's hyperventilating. Okay. Urine is cloudy with sediment and blood cultures were confirmed infection, which by the way, blood cultures take a few days to come back. We wouldn't know this yet because I'm assuming it hasn't been a few days. Okay. What action should you take at this time and why? I need to initiate oxygen, priority. I also need to lower this temperature. Okay. I also need, he's becoming hypotensive. His MAP is 62. We may need to start pressors or the provider may give another bolus of fluid to see if he's fluid responsive because he still may be dehydrated. 1 liter for a patient that's in sepsis is not a lot. Okay. What else? We haven't got the vancomycin. We need to initiate his antibiotics. We need to call the pharmacy and say, hey, send me my stuff. And then they're going to, did you check the refrigerator? Swear to God, you're going to hear it a million times. Yes, I checked the tube system and the refrigerator. It's not here.
And their
then,
bin, don't forget that.
Oh, and their bin. Well, some hospitals don't have a bin. And then we either call them relentlessly or we march our happy ass down to the pharmacy and get it ourselves. Okay. What stage of sepsis is the patient currently in? So he has reached septic shock, right? Because we're not at MODS because the lactic is 3.6. With MODS, your lactic is greater than 4. Okay. Septic shock, we're hypotensive. We have a high heart rate, decreased blood pressure, decreased urinary output. So what orders do you anticipate for Mr. McMillan, procedures, meds, transfer, etc.? Oh, and he may need respiratory support at this point within septic shock.
He's definitely going to ICU.
Yes, this patient is going to the unit for sure. This patient needs ICU support. Maybe a change in antibiotic after the urine culture and sensitivity. And when we get our blood cultures back, hopefully.
We need to know what the cause is, like if the x-ray shows like kidney damage.
So is the cause one thing? Is it multiple comorbidities? You know, he did come in with a UTI, right?
But they're checking is like
But we want to check everything. We want to check the KUB. We want to check the ureters, the bladder. Does he have pyelonephritis? Does he have hydronephritis? Is there something blocking the ureters? Okay. Do we need pressors?
Is his map going back up with the?
I don't know.
Or yeah.
Well, I don't know what the doctor ordered because there's 2 possibilities. The doctor's either going to order pressors or he's going to order a bolus. If the patient is not fluid responsive, you're getting pressors. So Mr. McMillan responds well to the first liter of fluids and antibiotics are initiated within an hour of arrival. The ED physician places an ART line and central line to initiate vasopressors. They order a norepinephrine infusion to be titrated to keep the MAP above 65. The critical care team asks you to prepare the patient to transfer to the ICU. Your ART line is 82/48 with a MAP of 58. Heart rate is 122. Your central venous pressure is 4. Respiratory rate is 32. SVR, which I don't require you to know, is 640 because I don't even know what that means. And your O2 is 90% on room air. Why is he still on room air?
This man needs oxygen.
Okay. He is showing signs of decreased perfusion to his brain, which is a decreased level of consciousness cardiac output with his low blood pressure. His skin is warm and flushed and his temperature is elevated because of the vasodilation in the non-vital organs. What does it mean to titrate an infusion to keep a MAP greater than 65? At this point, everyone has been in an ICU, correct? Have
Moving with the, like, meds around, like switching the dosage to make their MAP stay at a certain level.
So norepinephrine is Levophed. That is one of our 4 pressors, okay? And it's usually our first guy that we go to. And titration, we have titration parameters, okay? So in your MAR, you will have your titration parameters of what you can go up and down in micrograms usually it's every 5 minutes, but if your patient's dying, it's faster than 5 minutes. Okay. Yeah, so we can increase, titrate it up, or titrate on what our art line says for the MAP. And it is up to your nursing judgment and critical thinking to titrate those medications. So after 2 days in the ICU, a norepinephrine infusion and a total of 2 liters of normal saline, Mr. McMillan's blood pressure is stable. His MAP is 67. He's becoming more alert. Is now oriented to person, places, time. His blood and urine cultures were positive for bacterial growth. He has received multiple doses of vancomycin as well as antibiotics targeted to his specific bacterial infection. He is being weaned off the vasopressors and the providers hope he can transfer out of the ICU tomorrow. What explanation or education topics would you want to provide to the patient and his caregiver before discharge?
Early signs of UTI.
Early signs of UTIs. And remember, UTIs are not super common in men. So why is he getting a UTI? Does he have BPH? Does he have urinary retention? Does he have incontinence and he's not cleaning himself properly? Is he sticking things up there that are not supposed to be in there? People stick things inside their urethras for fun activities sometimes. I'm not yucking somebody's yum, okay? But it happens. And if it happens, then they need to be taught how to do that in a clean way. She said, I can't teach you, and I don't know. I'm sure there is a YouTube video, a Facebook group,
Cleaner.
toys, something. This is the last slide. Do we have any questions about the types?
A lot, but
Not right now.
Right now.
Okay. So. What? Yeah, I'm gonna try to upload it today. It's short, so it should upload easily. It's when it hits that like 5-hour mark that it gives me a hard time. Also, I have a pre-recorded lecture for the trauma that I am going to send out. It is your responsibility to watch it. It is like an hour and 12 minutes, I think. You must watch it on your own time, okay? Because we don't have time. Monday, we are going to do burns, and then we are going to go into a review, okay? Our final is Friday, which means I probably won't send out key points until Monday.
So we don't got no more tests, just the final.
Just the final. Oh, your ATI. Yes, your ATI proctor is on Monday. By the way, if you have not given me your practice A and B, you are not taking your proctor. They have to be done. I know I'm missing some. I am missing some, if you can believe it. So if you are one of the people that have not turned in your ATI, you must have it turned in with remediation before I go to bed on Sunday. Because I'm telling you right now, you will not take that proctored ATI. No, you won't. No, girl, I don't teach leadership. Get out of town. Any questions, guys, before I log off?
Very good.
Okay, let me know if you have questions. You're good to go. We did go 8 minutes over and I'm so sorry. But I'll see you Monday morning. You too.
Have a good day.